Thank you for introducing me, Dr. Choi. It's my great pleasure to share our clinical experience with international audience. Seoul National University Bundang Hospital has a government-sponsored specialized isolation unit to take care of hospitalized COVID-19 patients, including critically ill patients. For the last 3 months, almost 40 confirmed patients were hospitalized in this unit, and 5 of them were treated with mechanical ventilation and/or ECMO. Today, I want to talk about current situation of COVID-19 in Korea and clinical characteristic of the first 28 cases in our country and our clinical experience in SNUBH. The total number of COVID-19 patients in Korea is more than 10,000 with 232 mortality recently. And new cases has been decreasing with a strong quarantine and social distancing policy. The overall mortality of COVID-19 in Korea is approximately 2%, but the mortality in each age group is substantially different, with 10% in 70s and more than 20% in the 80s or older group. For the treatment of COVID-19, there has been no scientifically proven evidence or guidelines based on well-designed randomized controlled trial yet. Some potential candidate drugs such as hydroxychloroquine, Kaletra, tocilizumab, convalescent plasmas, or remdesivir can be used, and some positive results were published in case series or small RCTs. But the evidence is not enough to recommend the specific drug, and there are concerns about adverse reactions such as cardiac toxicity in hydroxychloroquine as well. We have not used hydroxychloroquine or convalescent plasma therapy in our institute yet. Instead, we are currently participating in remdesivir RCT. This is a blind study, so I cannot talk about the efficacy of remdesivir yet. We gathered clinical information of the first 28 patients with COVID-19 in Korea. The clinical severity was generally mild, and the most common symptoms were fever, myalgia, and headache, and respiratory symptoms such as sore throat, cough, and sputum. Runny nose and diarrhea was not very common. While the symptoms were mild, radiologically proven pneumonia were very common from the early course of the illness, with 50% in simple chest X-ray and almost 90% in CT scan. About 20% of the patients showed progression of pneumonia and required oxygen supplement therapy during hospitalization. In general, they needed oxygen therapy in the 1st to 7th day after the first symptom onset. Radiographic aggravation of pneumonia in chest X-ray was also observed in similar pattern from the 5th to 8th day after symptom onset. Therefore, close monitoring for at least 1 week after symptom onset is necessary for the high-risk patients who are in older age group or have underlying medical illnesses. When we analyzed a peripheral blood lymphocyte count according to the severity group, lymphopenia was more frequently observed in patients who needed oxygen supplement therapy. CRP values were also much higher in severe cases than in mild cases. Viral shedding was very high from the first day of illness in most cases, especially from upper respiratory tract, and decreased after 10 days. This is one of the most striking characters of COVID-19, and many patients who have mild symptoms can spread virus from the early in the disease course in the community. This is a possible explanation about why it is so difficult to control the large outbreak situation in most countries. Fever was generally resolved after 10 to 14 days of illness in most non-critical ill patients. In summary of clinical features, the prodromal symptoms of COVID-19 was generally mild. Radiological pneumonia was very common and developed from the early days of illness. Pneumonia may progress at 5 to 7 days of illness, and high titers of the virus shed from the upper respiratory tract during early days of illness. I want to talk about 3 COVID-19 cases in our hospital. The first case is a 55-year-old male who returned from Wuhan, China. He had no medical illness and had fever, chill, myalgia for 5 days before hospitalization. He had no respiratory symptoms and complained of mild short of breath only, while the temperature reached over 39 degrees Celsius and peripheral capillary oxygen saturation was only 90% with oxygen supplement. The initial laboratory test showed lymphopenia and elevation of liver enzyme and CRP. Urinalysis showed proteinuria and microscopic hematuria. Initial chest X-ray showed bilateral infiltration in peripheral areas of both lung fields. The CT scan showed multiple ground glass opacity in extensive areas of both lung fields. In spite of this severe radiographic pneumonia, the patient's symptoms were relatively mild, and he had only mild short of breath. This is a usual early presentation of COVID-19 pneumonia, that is, minimal symptoms discordant with severe radiographic findings as in other atypical viral pneumonia. We treated the patient with ritonavir-boosted lopinavir, Caletra, for 12 days. Fever was resolved in 2 days, but pneumonia progressed for the first 4 days. He had diarrhea with Caletra therapy. He was gradually recovered after 1 week of hospitalization and discharged after 2 weeks. We used Caletra for the treatment and the drug looked promising in treatment of this case. But thereafter, in other patients, we have experienced clinical deterioration in spite of Caletra treatment. Currently, we are not sure about whether the patient's recovery was due to antiviral effect of Caletra or it was just a natural course of illness. Let's move to the second case, it's mild case. A 40-year-old female was admitted due to febrile sense and throat pain for 5 days. She was infected by family contact. She didn't have any respiratory symptoms and vital signs were normal. Initial laboratory tests showed almost normal. Chest X-ray on admission showed no infiltration, but when you checked the CT scan, focal ground glass opacity were observed in the left lung. Her symptoms were very mild with some respiratory symptoms and anosmia, so we did not use antiviral agent at first. On the 7th hospital day, low-grade fever developed and new ground glass opacities and aggravation of the previous lesion were observed in the CT scan. Caletra was prescribed and after then, she was getting better. The CT scan on the 14th day showed resolution of previous lesion and some fibrotic changes. She was discharged without any complication. Let's move to the critical case. A 62-year-old female was transferred to our hospital due to fever for 8 days and short of breath. She had hypertension and schizophrenia. She had cough and sputum, and temperature was over 38 degrees Celsius. Peripheral capillary oxygen saturation was 97% with oxygen supplement. The initial laboratory test showed leukopenia and lymphopenia and thrombocytopenia. CRP was elevated and ABJ was as shown. The CT scan and chest X-ray showed multifocal ground glass opacities, mainly located in the periphery of both lung fields. Caletra with broad spectrum antibiotics were used, but pneumonic consolidation and hypoxia was aggravated within 4 days, and mechanical ventilation was started. We also used the systemic steroid considering acute respiratory distress syndrome. The clinical courses became worse, so inhaled nitric oxide and extracorporeal membrane oxygenation, ECMO, was applied in phases. Tracheostomy was performed early, and mechanical ventilation was continued for 4 weeks. Our intensivist performed a bronchoscope-assisted percutaneous tracheostomy and ECMO insertion on the bedside for the critically ill patients. After 1 month of hospitalization, she was successfully weaned off mechanical ventilation, and PCR result for virus showed negative after 1 month. After a short course of rehabilitation, she was transferred to a long-term mental care hospital. I want to wrap up my talk with some conclusions. Most of COVID-19 patients showed mild illness in our experience. A radiological pneumonia was very common and developed from the early days of illness. Pneumonia may progress at 5 to 7 days of illness. Mortality of COVID-19 was higher in elderly group, especially in their 70s or over 80s. Unfortunately, there is no clear evidence yet about what is the most effective antiviral treatment option worldwide. Therefore, the best supportive care, including mechanical ventilation and ECMO, is most important in especially critically ill patients. We are waiting for the interim result of remdesivir randomized controlled trial sponsored by the US NIH in May. Thank you for your listening.